Another frequent but often under-recognized finding is calcific tendinopathy of the subscapularis tendon. When calcification is detected, it must be systematically analyzed by size, border definition, internal echotexture, and irregularity. Most critically, always assess its relationship to the tenoperiosteal junction. According to our ongoing study, calcifications originate from mutant or transformed fibroblasts, or osteoblasts, at the tenoperiosteal junction. These cells form a capsule-enclosed vesicle of calcium. If these calcium-forming cells survive, the calcification gradually enlarges toward the musculo-tendinous junction, extending medially. But the lateral edge always maintains attachment to the periosteum. This attachment is a defining characteristic of early and growing calcifications. If a moderate-sized calcification is embedded within the tendon substance, especially if it has moved away from the tenoperiosteal junction, it may represent an active growth phase. On the other hand, a small calcification exactly at the tendon-bone junction may be a stable, early-stage deposit that will remain quiescent if the mutant cell dies early. For calcifications exceeding 6 millimeters, two possibilities should be considered. It may be a well-encapsulated, stable calcification formed by long-surviving calcium-forming cells. Or it may represent a post-rupture state, an irregular, disrupted lesion often surrounded by delamination of tendon tissue. In the latter case, I refer to it as the empty nest syndrome, a term I use to describe the residual cavity and scattered calcium particles remaining after rupture. These cases often show poor healing potential because of the low vascularity at the rupture site. If you haven't yet reviewed my detailed theory and classification guidelines on calcification, please see my previous videos in the calcification series.